This week on the BackTable podcast.
90% of job is urethroplasty. Every day we do 4 to 6 every day. Now patient comes at 8 o'clock in the morning. I ask him, have you come for consultation or surgery? He says, for surgery. I say, don't eat or drink anything. We do blood investigations. We have a full pathology lab, X-ray test, ECG, 2D echo, lab, everything. 1 o'clock I can make an incision if he's fit. And we do surgery with whatever money he brings in because this is my hospital. I'm a modern day Robin Hood. I take it from rich and give it to poor.
Welcome to BackTable Urology as we start another episode in Legends in Urology. You can find all previous episodes of our podcast on Apple Podcast, Spotify, and at backtable.com. Today I have with me the internationally known urethral reconstructive surgeon, Dr. Sanjay Kulkarni. He is talking to us today from his hometown of Pune, India. It's an absolute pleasure to have him here on BackTable Urology today to share about his life experience, his wisdom, and just to hear his story.
Thank you, Jill, for invitation.
Well, let's just jump right in. So tell me a little bit about what it was like growing up in Pune, India.
So Pune is about 3 hours drive from Mumbai. The current population is about 7 million and is considered Oxford of East. Is famous for its educational institutes. And I grew with my parents in a one-room home with 3 brothers. So my father was a photographer with the government and my mother was a homemaker. So I am the eldest of the 3 brothers. My second brother is an engineer and third one is a lawyer. And currently I live in what called joint home. That means in our home we have 7 or 8 bedrooms. We have 3 couples, 3 brothers, their wives, my nephew and his wife. So 4 couples live in the same home. We have 1 kitchen and 1 television. So this is happening for last 70 years. I am 70 years old now.
Wow, you've been doing that for 70 years. Does it feel like a tight space or are you just totally used to it at this point?
No, when I grew, that was a single room home. Then we had a 2-room home. Then we had a 4-room. Now we have an 8-bedroom house. So this is a progress that we have made over a period of time. But as a child, up to schooling, we grew up in a single room. So everybody came from middle class and that was my schooling time.
And what were you guys into as kids? Like, was it soccer? Or...
Yes, in India, cricket is famous and very popular. So we used to play cricket on the road with a bat and a ball. There are other sports like kabaddi, which you may not know, other Indian sports, and football. We call it football rather than soccer in India.
And it sounds like you came from it. You mentioned the town was the Oxford of India. So did most kids go on to college and was that pretty typical?
My father, because he was a government servant, had multiple transfers around the country, but he refused all his promotions because his kids, 3 sons, could get good education. And then we went to a good school and my mother took care of our studies and 3 brothers excelled in their studies.
And were you ever not thinking of going to college or you're for sure this is what I'm going to do? Was there any other path that you ever considered?
No. Going to college was essential. All of us are highly qualified. Our wives are also highly qualified. And this is the future. Education. My mother was very particular about it.
And did you know you always wanted to do medicine? Or did you kind of find that later?
No, when I was in school, there's a girl next door to me and my mom said, she's going to be a doctor. Why don't you become? So it was, so then I became a doctor for her sake. Otherwise, for the first month, I had taken admission to an engineering college. But then I changed over to medicine.
And you attended medical school in India, and then you trained in England. Walk me through kind of the path to become a doctor that you experienced.
So once you finish your schooling, we have to do 2 years of college. And then if you get good marks, and I was 7th in the rank being admitted to the BJ Medical College in Pune. We had about 200 students per batch. And my admission year was 1971. And I passed out in 1975. After passing out with flying colors, I was 3rd in the class. And then I was very good. I just want to tell you the story that in my 2nd year of my medical schooling, I did the first surgery of a Steinman pin. Interesting. And then being a large general hospital, which is about 2,000 beds. I used to go and read ECGs. I'm talking about medical school. I used to go to the pathology lab and take blood samples because there are a lot of people having injection. I used to give injections, do suturing as a medical student. Then once I finished my medical school, we had 1 year of internship and 3 years of surgical residency that I did in KM Hospital in Pune. And my teacher was so-called a Parsi. Parsi, that means their origin comes from Iran. And then he was one of the finest surgeons I have ever seen in my life. And then I learned a lot of surgery from him, 3 years of surgery. After finishing surgery, I went to England in 1981 for urology training. And I spent 5 years. And before going to England, I was married to my wife, Dr. Josna, who is a surgeon. So she is the senior most laparoscopic surgeon of India today.
Okay, well, we'll talk a little bit about that. Sounds like a very busy time. So let me ask, finished your time in India, which sounds like you got a lot of early experience and interacted with some great surgeons that influenced you. How did you end up deciding to train in England? And was that a hard adjustment, like moving from India to England with the climate and the culture? Like, how was that decision made?
So there are two things. In 1980s, the urology training was restricted to Delhi, Chennai, Vellore, only few centers. There was no center in Mumbai or in Pune where I could go. And all the seniors in Mumbai and Pune used to go to England. Point number one. And secondly, when I was in second year of surgical residency, when I was about 25, 26, my surgery teacher was learning TURP. I said, if he's learning at TURP at 50, because the only differentiating point between surgeon and urologist for TURP at that time, there is nothing else, no PCNL, no ureteroscopy. So I said, I must go and learn TURP. So I went to England in 1981.
So you went to England, and I noticed when you were there, so it sounds like you could see what was coming and you wanted a bigger and better experience, that you trained or had the privilege of training with Dr. Richard Turner-Warwick. Was that the 80s at that time?
So first of all, I want to tell you that I spent 2 years with Michael Heel, who was a student of Richard Turner-Warwick. Okay, and that was a peripheral hospital in Crewe, which is near Manchester. And at that time, I learned the technique of what called penile inversion. When my guru, he used to do cysto-urethroprostatectomy for multifocal TCC of the bladder. He used to do cystectomy from above. I used to do urethrectomy from below through a perineal incision with penile inversion. And then in 1986, I got a chance to work as a first assistant to father of urethroplasty, Richard Turner-Warwick. And that was a turning point in my life.
What was it like training with him? I mean, certainly you hear a lot of people say his name. As Leonard Zenman used to talk about him all the time. He clearly had a huge influence on people. So what was he like?
So he was a great surgeon, first of all. And suppose he's doing urethroplasty, I ask him a question, he would leave the surgery and answer the question for 20 minutes. That cannot happen today. So first of all, he was a superb surgeon, great innovator, inventor, and he was doing fantastic surgery. I was lucky to work with him and then learn the basics of urology. Whatever he has written in that time still stands the truth of time, still true.
It's funny you say that. I was going to ask you, do you still do things or anything you learned from him the same way? You know, what are the principles that he really impressed upon you or you took away from?
So when he was operating in 1986, George Webster had yet to invent the crural separation, inferior pubectomy, and supracrural rerouting, the next steps. So Turner-Warwick used to do bulbourethra mobilization, and then if the prostatitis or the posterior urethra is too high for PFUI, pelvic fracture urethral injury, he used to do transpubic urethroplasty. And I still do transpubic urethroplasty in young girls with fracture pelvis, and we get a lot of these girls. After earthquake in Nepal, the girls were sleeping and the wall fell down. You understand? Something like that. And we still do some transpubic urethroplasty in young boys with a pie in the sky bladder or double transection.
Yeah, I mean, many consider him sort of the forefather of reconstructive urology. Do you?
Yeah, I do.
Sounds like it. Sounds like he was amazing. And then, was it always your plan to move back to India and specifically Pune?
Yeah, so my wife actually, I loved to live in England, I would have stayed there. But my wife said, no, I want to bring my girls. I had 2 girls born that time. I want to bring them up in India. So we moved back to India beginning of 1987.
So there wasn't a lot of discussion. She said, we're going back to India, and you said, okay.
Correct. No, secondly, I wanted to spend time with my parents. This is an Indian tradition to look after your elderly parents.
Of course. I think it's always fun to hear about other aspects of medicine or things when I'm interviewing somebody. And I noticed, and you mentioned this earlier, your wife is a surgeon and she did a lot of laparoscopy, and it sounded like you did too. What were some of the cases that you guys did, back in the 90s? And did you guys ever operate together?
Yeah, so this is interesting. I went to AUA for the first time in New Orleans in 1990. And at that time, I went ahead of Josna, my wife, and then I went to Pittsburgh to stay with my cousin. And then there was there is a big ad in the newspaper saying that laparoscopic laser cholecystectomy. I wondered what this is. And this is before 9/11. So everything was very, no restrictions of any kind. I called up the hospital and said that, can I come and see this laparoscopic laser cholecystectomy? And she said, yes, come and see. So I went and watched this. There was no laser, but lap pole. And then I asked my wife to join me. We underwent training. This is in Oklahoma at that time. And then she learned laparoscopy when there was no clip applier invented. Very interesting. And then she bought the instruments, and she is the first female surgeon in India and second surgeon in India to do laparoscopic cholecystectomy in 1990. She started India's first animal lab in 1991 and trained hundreds of surgeons. So I used to hold the camera when she was doing lap col initially. I was an assistant.
Did you do any laparoscopy yourself or just assist her?
So initially there was only laparoscopic cholecystectomy, then appendicectomy, and urology was started by Ralph Clement. So I went to Ralph Clement little later in St. Louis, Missouri, and learned techniques. But at that time, nephrectomy was not a common operation. So I still do some laparoscopy. My favorite surgery is laparoscopic pyeloplasty. And in about a month's time, we will get the Da Vinci robot and we will start operating on the robot.
Here's what I'll tell you. After you start to use the Da Vinci robot, you will think that laparoscopy was fairly archaic as far as sewing. So that's really exciting. That's great.
Yeah.
Well, if we transition into some major milestones, you've done a lot of really creative and innovative things about establishing centers. So I wanted to ask you about some of those. So one of them was you established the Center for Reconstructive Urology in 1995. What made you do that? Why did you do that? And what was your original vision and thought for it?
So at that time, first of all, I want to tell you, when I was a surgical resident, there were 2 emergencies every evening. One was injection abscesses, because the general practitioners or the GPs used to use syringes which were glass syringes and they were boiled. So many patients had injection abscesses. Secondly, in the evening, we had to do abscess drainage. And secondly, there were patients for urethral dilatation. In the minor OT, the patient lying in a lithotomy position, you have the dilators, there is a kidney full of blood there. You understand? Patient is shivering in pain. So that was our vision of dilatation in 1980s. So when I started doing, because I was trained by Turner-Warwick, I started doing urethroplasty and the results were far superior. So I said that we must establish this center. So we started this center in 1995 and I named it as a Reconstructive Urology Center. And it was difficult to do surgery initially because references were far and few. Most of the patients were poor, but I kept on perseverance and patients paid. Now in our new center, last month we performed some 60 urethroplasties in 1 month, 60.
That's incredible. So did it meet your expectations? Was it mainly focused on you providing the care, or was it a training center, or did that come later?
No, so what happened, we established a small hospital because my wife and me, we could not go and do surgery other places. There was too much of equipment required to be shifted, including laparoscopy, because many hospitals did not have laparoscopy equipment in 1990s. And then this was a small hospital with 2 operation theatre and 20 beds, which we ran till December last year. And we performed about 400 to 500 urethroplasties in the center. And then we thought that we want to go to a bigger place, so we opened a 100-bed urology center 1st of January this year.
Yeah, no, we're definitely going to talk about that. So it sounds like you started it because of the way that urethral disease was being treated was, I'll use the word maybe barbaric. And then you had this huge skill set you learned from England that you brought back and started to do that in your hometown, India. So 10 years later, you opened up what I think is named the Karney School of Urethral Surgery in 2006. And tell me about that. How was that different? And what were you thinking when you established that?
In India, still today, live surgery workshops are very popular. So I was invited to many places to teach them how to do urethroplasty. And then people wanted to come and learn. So if somebody comes and stays in Pune for 7 days and I may not have enough cases, then his time may be wasted. So what we did, we started collecting patients once a month on a Saturday, Sunday, because urologists are busy Monday to Friday. They come to Pune on Friday evening, and Saturday, Sunday, we used to perform 8 to 10 urethroplasties in 2 days. So they come inside the theater and they watch it. So that's how the program started. And about 8 to 10 urologists came inside the theater each time. So this has been happening since 2006 till now. And then in 2010, Dmitry Niklauski from Syracuse came as a foreign visitor for the first time from Beaumont Hospital. And then it became popular around the world.
Oh, so at first you were training physicians within India, and now it's an international training site. So how many surgeons do you think you've trained? If you had to guess, how many people have come and visited you guys at this?
In India, maybe about 1,000, maybe about 1,000. But around the world, almost every country. At present, I have 2 Mexicans, 2 from Philippines, and 1 from Russia.
So Sanjay, I'm going to ask you a question. Can you tell right away who's going to be a good surgeon and who's not?
Yeah. It's like everybody cannot be Michael Jackson. You understand? So there are some inherent skills and some can be acquired. But some inherent skills have to be there. And when somebody is operating, then I can immediately tell whether he's a good surgeon or not. Recently, I just want to tell you that I have 4 fellows, 2 from GURS and 2 from local university, and the girl from Bogota, Colombia, and secondly from Argentina. I told my other 2 boys that the girls are doing far better surgery than you.
I think we have the same feeling here in the United States. So it's a worldwide phenomenon, apparently. That is amazing. Congratulations. That's really quite an accomplishment. So tell me a little bit now about your recent adventure and you call it the Euro-Kool hospital. Is that correct? And that opened up in just December of last year. So not even a year old yet. So tell me about that and how you guys, again, took another major step in opening that hospital.
So what happened, we had 20 beds and 2 theaters, and then the work was increasing. I had many associates, Dr. Pankaj Joshi, other people. So at present, we have 5 full-time urologists and 4 fellows. So 9 urologists work in our hospital. So in 2016, we started looking for a plot to build a hospital. It took us 2 years to find the right size, space. And then COVID came in, but then it was delayed a little bit. And then we opened this 100-bed urology hospital. And Euro is urology and Kool is Kulkarni. And in India, Kool means home. So this is home of urology.
Oh, that's clever. And you do everything there, like stones and urodynamics. And is it a full center for all of urology needs?
Now what happens, our 90% of job is urethroplasty. Every day we do 4 to 6 every day. Now patient comes at 8 o'clock in the morning. I ask him, have you come for consultation or surgery? He says, for surgery. I say, don't eat or drink anything. We do blood investigations. We have a full pathology lab, X-ray test, ECG, 2D echo, lab, everything. 1 o'clock I can make an incision if he's fit. And we do surgery with whatever money he brings in, because this is my hospital. I'm a modern day Robin Hood. I take it from rich and give it to poor. So we can do surgery for free. I don't have waiting list.
That's amazing. That is totally neat. So tell me, are you running the whole hospital every day, day in or day out? Or do you have anyone you answer to? Or is it you and your wife? Or how does it work?
No, this is a private limited company which I own. We have 5 operation theaters. And then we have 2 theaters for urethroplasty, 1 for endourology, 1 for laparoscopy robotic, and 1 for transplant, penile processes, and artificial sphincter. And we have 10-bed ICU, 10-bed dialysis. We will be starting kidney transplant. We will be starting robotic surgery. What happens, my juniors, The Pankaj Joshi does a lot of urethroplasties along with me. But my other colleagues, they can't leave endourology because they have not enjoyed the, what you can say, thulium laser, stone crushing or TUR, bipolar TURP. So we don't do a lot. We may be doing one TURP a week, one or two ureteroscopies a week. Not a lot, but laparoscopy we do reasonable, so we will do more robotic now.
Oh yeah, I mean, that's very exciting. I think the robot, you're going to love it, as many of us, I mean, I do a lot of it, as we do here in the States. So it'll be exciting to see how that goes there. I was going to ask you actually about the finances. You mentioned that patients bring whatever money they have. Is there any sort of private or government insurance, or is it just the patient pays whatever they can bring?
So in India, we have three different kinds of systems. One is there are government hospitals, then there are medical colleges. So there is something called as Ayushman Bharat. That means this is a government of India sponsored scheme. Half the population is covered under the scheme where they get treatment free of cost. But my hospital doesn't give treatment of free of cost because I'm not included in that scheme yet. Second is what we call charitable hospitals where the surgery is performed at a reasonable cost. And thirdly, this is a corporate hospital. Mine is a corporate hospital. This is something like a 5-star ultra-modern hospital. And then two things can happen. Because I own it, I can do surgery completely free. But normally, insured patients, which is about 50% of our patients, and some patients pay from their own pocket. We get patients from Africa, from Middle East, everywhere.
I was just going to ask you that. Has it become kind of a boutique place where people fly in to have surgery with you from around the world and now fly out?
That's true.
Wow.
They stay in Pune for 3 days. They come, they spend 1 day in investigation. We do surgery. 48 hours later, they go home.
Incredible. So you bring a lot of people to learn and train from you. Do you have the opportunity to learn and train from other people, or are you kind of set in your ways and this is how you're going to do it?
No. So whenever I go to AUA, EAU, SIU, I meet my colleagues. We are, as you are a part of our urology, urethroplasty group, where the group is about 200-300 experts. We meet and we discuss about each other. And for last many years, I have been conducting live surgery workshops. So where my mentor, Dr. Guido Barbagli will come, Professor Mandi will come. Dr. Jerry Jordan has been to my hospital. Howard Snyder came to my hospital. Then Alan Morey, Richard Santucci, a lot of American urologists have come and done surgery in my unit.
So you're still willing to learn, which I love, and pick up little tricks from other surgeons. I know we've all picked up a lot from looking at your videos and things that you've popularized.
Another idea is when the young urology group comes into 10 people inside the theater, on my right shoulder is a 4K camera and there is a 70-inch 4K TV in my theater. So even if you're standing next to me, it is better to watch on a TV rather than or directly to the patient because of magnification you see better. It's like using surgery with loops. And a young urologist may ask me question and that will stimulate my mind. I tell them that when we discuss about the because there could be multiple ways of treating the patient. So if somebody suggests and it is better for my patient, I'll change immediately. I'm willing to learn at this moment.
I love that.
And then what happens, I will do 2 urethroplasties on the patient. And I will not do the third one. And then when Guido Barbagli will come, Professor Mandi will come, I will offer my failures to them. So the important point is my ego does not come in the way of treating my patients.
Perfect. Definitely the right mindset. Certainly something I feel the same way about. Let me ask you a little bit about some of your awards. Clearly, you've been the president of lots of societies. You received an award that I wanted to ask you about that really stood out to me. It's called the Dr. B.C. Roy Award. Can you tell me about that and how you got that award?
So Dr. B.C. Roy was a very important doctor. He was chief minister of a state called Bengal, and he developed a lot of services So Government of India named the highest award the Government of India can give to a doctor. They named it after him, Dr. B.C. Roy Award. He was born on 1st of July and he died on 1st of July. And he was trained in England. So this is the highest award one can get from the Government of India. And it is given by the President of India in the Rashtrapati Bhavan, which is the President's Palace. So I want to tell you that the Indian President's living space
is about 300 acres. That means it's a large place. Some 300-400 rooms. This was built by Britishers, and it is the finest building in the world. So I took my mother, my brothers, and their wives. It's like going to White House to receive, or going to Buckingham Palace to receive the honors from the president. It's a rare honor.
It sounds like it was an amazing experience. And was that for your work in urethral reconstruction?
So to develop a new subspecialty in medicine.
Got it. And speaking of that, we were exposed to a lot of different types of medicine. You mentioned it early. You had a lot of exposure when you were a medical student and different surgeons. But what is it about the urethra that you've chosen to really focus your career about being a urethral reconstructive surgeon?
So what happened, once I started doing urethra initially, first 10 years from 1987 to 97, I was doing lots of anastomotic urethroplasty for bulbar urethra, which was common at the time, transpubic urethroplasty, occasional flaps. There was no buccal mucosa. So 1997, I went to England where Professor Mundy, George Webster and Barbagli, I met them and I was introduced to this dorsal-only buccal mucosa technique. And then I picked it up and brought it to India. And it was very good for bulbar urethra. So I said, why not use it for penile urethra? And then I had some patients where I had to use it for pan-urethral stricture. And in 1983, I had learned this technique of penile inversion in England for urethrectomy. So I applied the same technique and I published my first video year 2000 in AUA. Then 2009, I published the one-side dissection technique. After Barbagli published the muscle sparing technique in 2006. So everything had a little history. The important point in my life is around 2002 when Jerry Jordan, Barbagli, Mundy came down to Pune for my first major international workshop. Dr. Barbagli asked me, Sanjay, what is your interest? I said laparoscopy and urethroplasty. He said, Sanjay, forget about laparoscopy, keep on doing urethra. That was the beginning of turning point in my life. So you must have a mentor. What is important is Roger Federer, the greatest tennis player, still has a mentor, has a coach. So everyone should have a coach and he should be able to tell you in your midlife what is right, what is wrong. And you should be able to accept it.
So Barbagli gave you your marching orders, right? He said, nope, you're going to do the urethra, and that was it. Okay, love it. Do you think there's more to be discovered in urethral surgery? Some people say, hey, we as a field have done a really good job and kind of mastered it. Or do you think that, we still have opportunity in urethral surgery?
I think this is the branch where a lot of new inventions are coming up compared to any other subspecialty in urology. So I think that majority of the urologists around the world are endourologists. So the future of anterior urethra, posterior urethra will remain same because the road traffic accidents and except for endoscopic railroading, surgery will be there for anastomotic urethroplasty. The stricture may be simpler. For anterior urethra, what I think, for bulbar urethral stricture, one may do DVIU and one of the Dmitry Nikolowski's, liquid buccal mucosa or inject him some kind of cells manufactured in the lab or maybe some totipotent cells may be used to regenerate the urethra locally. Hypospadias strictures again will remain. So there is some progress being made, and this optilium balloon, which is again advances, so something new will come up definitely, but it will be more endourological rather than open surgery.
Got it. So you feel like the field's going to continue to advance, but in more of a minimally invasive way.
Correct.
And are you yourself interested in stem cells or tissue engineering? Or are you doing any work with that?
So we have a lab where I am now in Lonavala. So what we did, we took a small piece of specimen from the cheek under local anesthesia, sent it to lab. They grew into multiple buccal mucosa cell culture. So I saw Dr. Barbagli do ventral-only buccal mucosa, making the incision and then applying this cells on a substrate which is absorbable. So I thought, why to make an incision? So we took a knife, doing DVIU and injected the cells with a glue inside. The initial results are reasonable, but we need long-term follow-up.
So it is something you're looking into. And actually, you're right. A lot of people are. And you can see a world when we will just make an incision and fill the valley or the gap with stem cells or something, some nutrients to try to have regenerative healing. So I totally agree with you. You talked a little bit about the robot. I was going to ask you about that. You may like it so much you may hang up your urethral skills and then just pivot over to the robot once you get it. Are you really interested in that, or is that for somebody else, you think?
I'm interested in Lee Zhao's work because he has done fantastic robotic reconstructive urology for prostate bladder neck area. As the number of robots increase, that will be my work mainly. So whatever I'm doing transmimically or those complications of prostate cancer surgery or radiotherapy, I'll be able to do a job according to what Lee Zhao and others are doing. He is a leader.
Perfect. So you already have a vision of how you're going to utilize the robot in reconstructive urology. Even for myself, it is such a great tool. So I'll be excited to see, how you utilize that and how your practice grows. So you mentioned before some of the people that influence you, including your peers, Turner-Warwick. Is there anybody else in your career that really was like pivotal in helping you develop outside of urology or inside?
Professor Mandi is also very important in my life because I consider him another of my mentor, and then the way he performs surgery, we learn from. I have seen lots of videos of George Webster, and then he is a fantastic surgeon. Jerry Jordan, I have seen him personally in India. So I think we pick up points from every urologist. Jack McAninch, we considered a father of American urethroplasty. America is really a fantastic place because Jack McAninch, Jerry Jordan, George Webster, everybody, Lenny Zinman, all important people. Significant contribution.
Definitely. So let's talk about your significant contribution that I think we'll say to each other as reconstructive urologists, oh, did you do a Karney? So it's become a commonplace word, and that's to your credit for one of the techniques that you've definitely popularized. So what was the original Kulkarni urethroplasty?
Yeah, year 2000, there is a video in AUA, which you can buy, I'm just saying, but it's available. So perineal incision, penile inversion, and then mobilize the urethra circumferentially like Barbagli for penile and bulbar urethra. So that was considered little too aggressive. It was not popular. And then opening the urethra dorsally, and then applying a graft dorsally and closing, and then pulling the penis into normal position. That was initial surgery. But the urethra was separated away from the corpora cavernosa completely. So that was considered little too aggressive. But when I published the second modification, where I mobilized urethra only on one side, then the dorsal neurovascular supply to the urethra on the patient's right side was kept intact. I did not mobilize the urethra circumferentially, and then it became penile inversion, one side dissection, dorsal only became popular. And then it was published in Hinman's Atlas of Urology, and then it became. So Sean Elliott also came down to Pune.
I would say, Dr. Kulkarni, Sanjay, like that is what most people would say, the penile inversion, unilateral dissection for panurethral. And you've already talked about the big advancement in the technique. And I think now people, when they refer to a Kulkarni, often they just mean unilateral blood preservation for the urethra. Would you agree?
I agree. Because it can be used for penile, bulbar, and for panurethral stricture. Single surgery can be applied to 3 different places.
So in an opposite kind of direction about technique, are there techniques that you used to do that you would never do again because they just didn't work and just you abandoned them?
I don't like perineal urethrostomy. Okay, because what happens most of the time, perineal urethrostomy is performed for strictures which are distal to bulbar urethra, mid-bulbar onwards. And then in India, what happens, we have patients who have proximal bulbar, bulbomembranous strictures. So if you have a flap which you can insert inside, your diversion is not proximal, diversion is distal to the problem. And doing dilatation of perineal urethrostomy is trouble. Secondly, what happens is as a patient grows older, he has to sit down. So sitting down and getting up becomes difficult because he cannot pass urine in a public place. He has to sit down, pull his trouser down. He has to find a toilet. I don't like perineal urethrostomy. I do it only after surgery for penile cancer.
Great. So you're an anti-perineal urethrostomy. I get it. For lots of cultural reasons. It's difficult and hard, and those things need to be considered. Do you ever use it as like, gosh, I've operated on this person 4 times and we just can't get them open? Or would you rather have a suprapubic tube instead of a perineal urethrostomy?
That's very rare. So I told you, I will do 2 urethroplasty. Third one I will keep for my colleagues.
Okay, sounds good.
Offer them the best answer. And then suppose it fails, then I ask the patient to do self-cath. So there are some patients. So what's the indication of self-cath? The patient is unfit for surgery, patient refuses surgery, or after multiple failed surgeries.
Got it. That's your preference. Okay. When we talk about technique, are you a stickler for where the surgical knot goes? When you're putting down a dorsal buccal graft in a urethroplasty, do you care if the knot is on the inside or the outside when you're sewing it down? Do you think that technique matters?
So actually for dorsal only it does not matter a lot, but when I do anastomotic urethroplasty, Richard Turner-Warwick used to say that principle of plastic surgery is less fibrosis. So not in the lumen versus not in the tissue. Not in the tissue causes more fibrosis because you have a number of throws. There is a bunch of suture material inside tissue. So what he suggested, if the knot is in the lumen for anastomotic urethroplasty, it will fall off. So knot in the lumen is ideal for anastomotic urethroplasty, according to him.
Got it. So you like to put your knots on the inside anytime you're doing an anastomotic urethroplasty. Have you adopted much of the non-transecting urethroplasties, or is the scar just too dense that's you're fixing most trauma patients or crush injuries, so it's just not quite as applicable?
So in our unit, suppose I do 600 urethroplasties, I may transect the bulbar urethra not more than 6 times, only when there is urethral trauma. Otherwise, we use this non-transection technique, and then we have introduced this Zoshi step, my associate, where we don't excise anything. We just pull the dilated lower urethra to the upper urethra and just put sutures there. We call it Pankaj Joshi step, which is before Mundy's mucosal anastomosis step.
Okay, so you're making an incision and then just pulling the tissue back together.
And creating a wide urethral plate. Otherwise, what happens? Suppose there is a short stricture which is 5 millimeter in length and only guide wire goes inside. That means the urethra is only 3 French. And if you don't take care of the narrow urethral plate and apply buccal graft dorsally, then the 3 millimeter 2 edges will close down and the graft will remain outside the urethra. So you have to take care of the narrow urethral plate. If the stricture is short, then Joshi step or mucosal anastomosis. If the gap is longer, double phase buccal mucosa.
So you guys are still progressing your technique, which is great to see. I think many of us are similar, that we rarely transect the urethra anymore unless there's just so much dense scar that we're forced to do it. Do you have a favorite surgery? Of all the different surgeries that you do, is there one that you just really love doing? Any type?
I like posterior urethroplasty because I'm really good at that. My average time for posterior urethroplasty, including crural separation, inferior pubectomy, is about 1 hour.
Incredible. And sometimes you have to do a pubectomy and you still get it done in an hour?
That's about an hour more.
An hour more. And how often would you say that when you do a posterior urethroplasty, you're having to go through the 3rd and 4th step? You know, we know you mobilize and split the corporal bodies, but how often do you have to do a pubectomy or a corporal rerouting?
So in India, my pubectomy rate is around 50%. And then supracrural rerouting, there are specific indications. I may be doing it about 3% of my patients. I will give an example. There is an adolescent boy, age 12 or 13, and then his penis is not fully grown yet. And then he comes with 2 failed urethroplasties. Okay, he comes with a suprapubic catheter. Each time you transect the urethra, it becomes shorter by 1 centimeter. Now, if I go 3rd time, the anastomosis is under tension. At that time, I'll do supracrural rerouting rather than substituting that big gap with a pedicle preputial flap or a tube, because there are 2 anastomosis and a skin-lined urethra which will form a diverticulum. So I will take a risk of failing, but I will do supracrural rerouting in a young adolescent boy. But I don't do it routinely because the urethra gets engulfed in a bony tunnel.
Yeah. Sanjay, I think you have a really large experience compared to many of us with pediatric urethroplasty cases. So I guess my question is, just globally speaking, do you feel that if they have severe hypospadias or they have severe disease as a child, we should be as aggressive in reconstructing them, or should we wait till they go through puberty and so we don't run into some of these issues that you've raised? So do you have an opinion on that or some advice for some of our colleagues?
So unless one is really a hypospadiologist, a real expert like Snodgrass or somebody like this, like Miro, then he can do urethroplasty for hypospadias. Otherwise, doing surgery
with high surgical failure rate and fistulas is a trauma to the child. And then I think it's better to refer the patient somewhere else. You can do surgery at whatever age you want, but doing surgery for distal hypospadias is mainly cosmetic, like a coronal, subcoronal. There is no functional importance if the penis is straight, unless the meatus is narrow.
I fully agree. I guess the question I was trying to get at is there any benefit sometimes to letting them go through puberty and grow and develop prior to doing, a third major reconstruction? That was what I was trying to ask.
I agree with you. Then secondly, what happens, I have patients where multiple hypospadia surgery was done. Now the man is married, has children, and he comes with a stricture later on. I do first stage urethroplasty now, Johansson, and he's happy. So he goes back to his original hypospadias after childbearing is finished.
An interesting circle of life, right?
Yeah. He may not want the second stage because his penis is straight, he can have sexual intercourse, and then he has no problem of passing urine and no repeated UTIs.
Yeah. When we were at Leahy, we looked at this when I was with Dr. Zimin, and Alex Vani was out there, and about 25% of patients, as you said, did not go on and have it reconstructed. So let me ask you this, what advice would you give to a young surgeon, how to be excellent, how to kind of find their passion for surgical technique or types of surgery? What advice would you give to a young surgeon?
No, one must be obsessed with what you call excellence. And then one should go and visit centers of excellence. There are so many centers of excellence. I gave you so many names in America like Jack McKinney, Jerry Jordan, are now the current generation leaders. You should go and watch them surgery inside the theater. That's very easy in India, but may not be easier in America because you need a lot of tests to be done. But attending live surgery workshops in India is becoming very popular. Currently, I am president of Urology Society of India, and this year I have attended many workshops for stone surgery, for laparoscopic or robotic, urethroplasty. So we have to go and pick up points from everywhere and then go and see. I always wanted to go and see somebody who has invented an operation, how he could think differently and why I can't do that. So this year in AUA, I gave a talk in plenary. So what was the topic of my talk? So this is SIU lecture in Chicago. If we all follow guidelines, then who will invent? So I tease the American audience saying that how many urologists undergo TURP? Rare. PCNL? Even rare. So what we advocate to the patient, we are not willing to do on ourselves. And then if you think that you are the patient, if you are not willing to do something on yourself, you may think alternative out-of-box thinking, and that's an invention.
Yeah, that's where innovation can come from. I fully agree. And you may see in one of my talks, and I'll quote you, I love that, obsessed with excellence. And I'll put Sanjay Kulkarni. So reflecting back, when you think about the field of urology and you've seen it change and grow with laparoscopy and robots and all the changes in urethral surgery and stem cells and buccal graft, does anything really stand out to you as being really exciting, or is it just in general you're an innovative person, but does anything stand out to you in how the field of urology has changed?
I think it has changed for the better. It is changing continuously. I really want to see young people, and my favorite is Dmitry Nikolaevsky. His thinking is completely out of the box. And then the Pankaj Joshi is there. There are many more in America, and then they will take it further. I have an interesting quote. When two doctors agree, the progress of medicine is stopped. So we can disagree, and then we can find alternative pathways of treating the same patient, and both could be right.
I fully agree. That's how we progress the field forward, by having discussion. So let me ask you a final question. It's been really fantastic to get to interview and talk to you about your life and your work. Would you work a little harder, a little less, or do you think you got it just right? Clearly, you've had an amazing career, so many highlights on a national, international level. And the beauty of it is it just kind of all came to you. It wasn't planned. You just went for it. You had that creative mind. So what do you think? Would you do it the same again, or would you change anything?
So I would do the same again. If I'm lucky, I've been able to go to 50 different countries to demonstrate and teach urethroplasty, including Germany, Italy, many places around the world. So making friendship around the world was vital. And the disease pattern in Africa is different from what we see in America or South America or Canada. That's point number one. Number two is go for centers of excellence, visit them. And then I have been a visiting professor to more than 20 American universities. Now, next year, I'll be going to Mayo Clinic, the most important hospital in America, as a visiting professor. This is an honor. So the work will speak, provided you want to give the best possible to the public.
Great. Well, thank you, Sanjay. It's been a pleasure to interview you today. What an amazing story. To our listeners, I hope you enjoyed this episode as much as I did.
Thank you, Jill. Thank you very much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by G. Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.